Okay, good morning. Thank you all guys. Today is the last day for transferring live case to mainstream 360. So I think today is also the conclusive day to finalize the transmission for pilot session. Today we will have two cases, coronary cases with very complex lesion. So now is the first case from Nanjing First Hospital. Dr. Ge and his colleague is ready. So go ahead to introduce the history of the patient.
Okay, thank you, Professor Chen. And I'm very honored to here to navigate for the midstream 360. And first of all, I want to introduce our team. Is on my right is Dr. Gou and Jerry and the nurses and the image technician Dr. Pan. And firstly, I would like ask Dr. Gou to introduce this patient clinical information. Thank you, Dr. Gou.
Thank you. It's my honor to introduce this case. Next. This patient is 82-year-old female. She was admitted into our hospital due to sudden chest pain for 1 month. This patient received prior PCI due to acute myocardial infarction or anterior wall on May 23rd, 2023. She suffered from essential hypertension for several years. Lab test at our hospital showed her renal function was almost normal. BNP was slightly elevated. ECG found T-valve inversion in leads V1 to V6. Echo found abnormal motion of anterior wall and her left ventricular ejection fraction 55%. She was diagnosed as unstable angina or MI and essential hypertension. Next. This patient, 1 month ago, this patient received emergency coronary angiography due to acute myocardial infarction. The baseline angio showed only mild stenosis in right coronary artery. Next. From AP cranial view, we could find diffuse severe stenosis in LAD because ECG found acute myocardial infarction or anterior wall. The lesion in LAD was the cover region, so 2 drug-eluting stents were deployed in LAD successfully. From AP core view, we also could find severe stenosis in from proximal to distal left circumflex involving obtuse marginal branch, very big, large obtuse marginal branch. It's Medina 011 bifurcation lesion.
And clinical information. And this patient, summarize this patient, and today's target lesion is circumflex and OM and bifurcation lesions. From the angio, today's angio shows on the screen. Yeah, this from the angio we can see the LG stent is expansion very well. And the circumflex, approximate circumflex is significant stenosis with the severe calcification. And circumflex and OM is the true bifurcation lesions. And we can, the OM is bigger vessel and circumflex and bifurcated 3 branches. And we can see the circumflex, distal circumflex is diffuse lesions, but it's not big vessel. And so I want to use the IVUS to assess this lesion and to decide what is the strategy to do. And so next. So next. Okay, so we did the IVUS for the OM and the circumflex. And first, before that, we used the 2.0 and semi the compliant balloon to pre-dilate, use the low pressure pre-dilation, and check IVUS for the circumflex and OM. And Dr. Pak, can you interpret the in IVUS imaging?
Okay, let me show the IVUS imaging. The first one, we check IVUS from distal circumflex to proximal circumflex. And here we can see the distal vessel is very small. The vessel diameter is just 2.0 millimeter. Then go and pull back, we can see eccentric plaque. And go and pull back here, this point we can find this is a minimal lumen area. The area is just 1.5 millimeter square, and the plaque burden is about 60%. Then go on probe back. Here we can see find the bifurcation. Here this is the PL and the circumflex bifurcation. The netness from the distal landing root to the circumflex and the PL bifurcation is 20 millimeter. Then go on probe back. Here, this point we can see find the stent landing root, and here the vessel diameter is about 3.5 millimeter, and the lumen diameter is about 2.75 millimeter. Then go on probe back. Here we can see eccentric plaque, and go on probe back. This is near the circumflex and the OM bifurcation, and here we can see the guide wire. Then here this is the bifurcation. This point, the area is about 1.8 millimeter square, and the plaque burden is more than 75%. The netness from the standard landing root to LAD and the circumflex and the OM bifurcation is just 7 millimeter. Okay, the second round we check IVUS from the distal OM to left main, and here we can see the distal vessel is normal. The vessel diameter is about 3.0 millimeter. Then go on probe back, we can see eccentric plaque. Then go on here, this point is the minimal lumen area. The area is just 1.6 millimeter square, and the plaque burden is more than 80%. Then go on probe back, we can see the circumflex guide wire. And here, this is the circumflex and the OM bifurcation. Then go on probe back. This is a proximal circumflex. The proximal circumflex, the plaque burden is very large. And here, this point, the area is about 2.0 millimeter square, and the plaque burden is more than 88%. Circumflex. Then go on probe back. We can see this is a Austin circumflex. This is a LAD. We measure the netness from the distal landing root to circumflex and the OM bifurcation is about 12. And the netness from the distal landing root to the ostium circumflex is about 41 millimeter. Okay, this is a baseline IVUS imaging. Thank you.
Today, we will treat this non-comprehensive vessel.
In general, almost 25 to 30% of patients with acute myocardial infarction have the multiple disease. So the complete revascularization for non-corporate vessel is a challenging issue. The two studies report the benefit of in-hospital stage PCI. It means the time interval between primary and stage PCI vary from 1 day to 7 days. And another two studies reported the benefit of stage PCI, which was done after 1 month, between 15 to 30 days. So this is why we need to design stage PCI to compare the different time point of stage PCI to benefit the patient with acute myocardial infarction. So also in terms of the study trial, after primary PCI, for non-corporate vessel, we need to calculate the QFR. So from epicaudal typically angiographically, there is a very severe disease at the proximal circumflex with mild to moderate calcification, and 3 small branches taken from the circumflex, and the obtuse marginal looks very big. So Gerchen, you have pre-dilated the small branch and check the IVUS for both circumflex and the obtuse marginal. So what's your next step?
Yeah, that's a great point. For this is circumflex and OM bifurcation lesions from the IVUS imaging give us more information because the OM is a very big vessel and distal circumflex is a very diffuse lesion, and this is very small vessel, just a 2 millimeter diameter. So from this IVUS imaging, so probably we want to use the OM as the main vessel and the distal circumflex as the sign branch to do the two-stand technique for these bifurcation lesions. From the IVUS imaging, the proximal, the circumflex with the calcification. So use the 2.5 specs angiogram, 2.5 the scoring balloon to predilate the proximal circumflex and the distal and then the circumflex or the OM, proximal OM.
Pantal, could you show the IVUS image for proximal circumflex to identify if there is a calcified nodule or the plug features?
Okay.
Yeah, this show the IVUS.
Proximal circumflex.
Yeah, this is the proximal circumflex.
No, so no calcified nodule. So usually we prefer to use provisional standing technique for tissue left main bifurcation lesion. But for this case, because already was infected 1 month ago, so it means the circumflex will play a very important role in preventing ischemia. So the careful protection of any even small sub-branch from circumflex will be very important. Another point is that patient is 82 years old lady. So I think maintain the TIMI-3 blood flow in cell is the key, is our goal. The point is that according to our definition criteria, so the lesion according to the geography could be classified by Medina 011 with a diffuse lesion in side branch. So I think it would meet the criteria for complex bifurcation lesion.
Great.
So this is the stem balloon, right?
Yeah, it's stem balloon.
Yeah.
Ooh.
So according to the standard of decay quality technique, after standing side branch, because the side branch stem is adjusted according to the distal circumflex size, so it should be undersized. It's small, much more small than proximal circumflex. So after stem, we need to slightly withdraw the stem balloon to optimize side branch stem. An alternative technique is to use another NC balloon to post-dilate side stem to make sure the side branch stem is the fully expanded, very well post. So now after standing side branch, Dr. Green, say you remove the side branch wire. So I feel the wire from the proximal cell, but still some resistance. Some resistance?
No, I believe it's not.
Okay.
16.
So once successfully rewired, so this is not 3ONC balloon in that branch to do alternative inflation at 16 atmosphere, followed by alternative inflation in the obtuse marginal. Finally, post-casing balloon inflation will be on schedule.
Okay. 8. Okay, great.
So for any casing balloon inflation, we always recommend to keep short overlapping of two balloons in the main vessel to rebuild the metal carina, which is very important to minimize to reduce the thrombosis.
After main vessel standing, I use the port balloon to do the port for the proximal circumflex. So here is a port.
Yeah, another trick is that for this patient, because you also need another stent for proximal circumflex.
Yes.
Before that, if you did not do post dilation for the first stent, it would be very difficult for some cases to get two stents overlapping each other.
No, it's used. They use another non-compliant balloon. 3605.
3.5的新的。
This is the 4.
Yeah, it's not for 35, but because they used, so it's not cannot cross. Use some. I think that use a new one.
Once we perform the balloon inflation in main vessel, so the shift will be back to its previous position.
Okay.
So the final case in balloon inflation is to try to keep the corona at the central
Very
position. Because this is the AV caudal, so the proximal circumflex was shortened too much.
Yes, good.
Take a photo. Good. Good.
Yeah. Okay.
No distal complication.
Good. Yeah. Test. Cine. Good. I think it's a good position.
Good position. Very
Yeah.
good. 1
Yeah.
millimeter overlapping.
Mm.
Very precise. Very, very.
去买别说，蛮好。
Distal OM. The normal
So
vessel is 3.0.
distal is 3.0.
Yeah.
0.
Little bit larger than 3.0.
The
Okay.
distal stand
This
edge
stand
is normal.
It's beautiful.
No
Not
dissection.
normal. Beautiful. Distal stand.
Then
is,
diameter distal is maybe
yeah, is,
2.5.
Right.
Not very large.
Very precise position. So what's a minimal scan area for proximal circumflex and for obtuse marginal? How long distance? 3 or 4 millimeter?
4 millimeter.
4 millimeter.
Let me see.
Okay.
Test a little bit.
So you can
Yes.
pull the NC balloon very close to the distal edge.
Oh, here you can see from the angel. Okay. We'll start.
This is a 3.0.
0. Yeah. 16. Good.
Very good.
Mm.
So after post-dilation, we need to have IVUS imaging again.
Yeah. Test. Okay. Start.
2 minutes left.
Yeah. Okay. Yeah, I'm ready.
Ready.